Conversations podcast.
Welcome to this podcast in which I have the great honor and privilege to welcome my friend and colleague, Dr. Jim Hlavac. And our topic for today is interpreting in mental health settings. Now, Jim, you probably know that I have a special interest in mental health interpreting because I teach healthcare interpreting semester 1 is all about the body, anatomy, physiology, pathology, interpreting for people with a range of conditions. But in semester 2, I talk about different mental health conditions, different approaches, but it's a huge topic. And I always ask my students to read from cover to cover, of course, the wonderful and very comprehensive guidelines that you published on interpreting in mental health settings. And I've always wanted to ask you, how did you get to write these? How did these come about? What was the impetus for you to write these guidelines?
Ineke, firstly, thank you very much for the invitation to be the guest on this podcast, and it's a pleasure to be here and to talk about a topic which is a big topic and one which I've come to get quite close to. But in relation to your question, how I came to mental health interpreting, it's been a long path. I might be reflective of lots of interpreters, I might not be, but when I think back, I first engaged in this type of work, well, it was overseas, working with war refugees, where I was working with social workers and also with doctors. And a lot of the time it was with, there were doctors administering prescriptions for people to take antidepressants, etc. And partly also from my own family background, I've known other family members where that's, if you have a problem, you take pills. And I thought that that's the extent of what happens with mental health conditions. And then here in Australia, I was working with lots of, I thought they were doctors. Well, they ended up not being. There were people like psychologists, mental health nurses, occupational therapists, etc. I didn't always take in who they were, what they did, what their job was. And I guess the penny started to drop for me when I started to work with counselors or trained psychologists who were leading therapy sessions with people or men, they were always men, who had received court orders to attend anger management therapy with a counsellor. And what I found with these interactions was that the counsellor was a psychologist, and I didn't even know at that stage the difference between a psychologist and a psychiatrist. A psychiatrist is a qualified doctor and can give prescriptions, can prescribe pharmaceuticals. A psychologist cannot. A psychologist works with their clients purely through therapy, talk therapy, speech, communication, etc. And when I was working with these counselors, I was kind of waiting for when are they going to give them the pills to kind of fix them up. It's quite naive. It was quite ignorant. I didn't know really the type of clinician I was working with, and so I was aware that I was ignorant. And I thought to myself, I need to find out who I'm working with in order to be a better interpreter. But also, it was also an area of interest. Anyway. So I would often ask myself, why is this psychologist asking a question which I thought this is quite inappropriate, really, or answer with complete silence? What's happening here? So I started to look up types of theories that counselors engage in. I had the chance to debrief with psychologists sometimes, and I would often ask them more questions than I would field questions from them. And so this is how my interest developed. And I realized that I needed to know about the settings. I needed to know about treatments and diagnoses. I needed to know, when I worked with a CAT team member, I didn't even know what the acronym stood for. It stands for Crisis and Acute Treatment Team. And they're talking about risk, harm, self-harm, etc. And if you know about these things, you can anticipate or at least understand the types of questions or things that will come out of people's mouths, or whether they're signing, if they're signing for that matter as well. So, these are things that started to interest me, and I then was fortunate enough to approach WITS, or Language Loop as they're now known, who funded a project on mental health interpreting, and part of it was a study, and another part of it was the production of guidelines. So that's really where the guidelines came from, and they were released in 2017.
They're still very, very relevant today.
That's right. Yeah, look, when I was doing research, there's quite a bit of research for clinicians on how to work with interpreters, but there was precious little for interpreters how to work with clinicians. And there's a real gap. There's a knowledge gap. So, and for me as an interpreter, this was the obvious area to address. So the guidelines try to be comprehensive. They talk about the terms patient, and sometimes the term patient is not preferred by some, and they prefer the term user of mental health services. I talk about job titles: psychologists, psychiatrists, mental health nurses. I talk about settings. I talk about the WHO, that's the World Health Organization, 10 categories of conditions or disorders, as they're still called. I talk about treatments. I talk a bit about legislation and laws, because part of your work can also be, in Australia, or in Victoria, they're called the Mental Health Tribunal. In other Australian states and territories, they have similar names, but in effect, what you're doing is you're working with a panel of members. One is usually a doctor, one is usually a lawyer, and the other person is a lay community member. And there are submissions from family, social worker, etc., social workers, etc., for a person who has been on an involuntary treatment order. Right? So these terms, involuntary treatment order, you need to understand what they refer to. And before you go to the mental health tribunal, what actually happens there? Who's presenting? What's the purpose of the panel? And the more information that you have about how these settings work, the better the interpreter you can be. Because as I said, you can anticipate, you kind of know where people are coming from. You know, the job of the interpreter is really to get into the to kind of see things from the perspective of the person for whom they're interpreting, to see what their intent is, you know, behind what they're
Because we've
saying
all
or
been in
signing.
situations where we didn't get that sort of information beforehand. I remember turning up to a job, all I was told was the name of a person I was supposed to be interpreting for. Arrived there, they were screaming, and they were going to be the subject of what we call compulsory treatment order. And the mental health professionals said to me, well, you speak Dutch, why don't you stay in a room with her? And I thought, whatever gave you that idea that it would be safe for me to be by myself with a mental health user in a room, when she knows full well, because her English was very good, that you are going to administer a depot injection. At the time, it was still lithium. And I just thought, no, there's no preparation. There's no ability for me to prepare. There was no briefing. There was no debriefing. It was just very ad hoc. And I felt, even though I knew, because of my nursing background, I knew about different mental health conditions, I just lacked that knowledge that would have helped me prepare. And I think that the mental health professionals themselves also were not used to working with interpreters. And you touched on the fact that different states in Australia have different legislation. And of course, this podcast is also for people in New Zealand. So again, we have different legislation in New Zealand, and it keeps changing. You mentioned the World Health Organization. They also keep changing the way they define different disorders, like bipolar disorder. There's now subcategories, and one is, I think, is the main criteria there. They've now added high levels of energy, which of course then translates into people perhaps speaking very fast and not wanting to stop. So we can't, as interpreters, say, okay, after, put my hand up, may I please interpret now? We wouldn't say that, but we can't stop patients. So what are some of the main things that you want interpreters to take away from the guidelines? Because basically you're covering professionalism, being prepared, briefing, debriefing, but also an ethically grounded approach to interpreting in the mental health setting. What are the main things that you want people to take away from these guidelines?
There are a few things, but I might go back to the first point that you mentioned there, Ineke, about not receiving a briefing. It's really important that the interpreter receives a briefing from the clinician about what the interaction is going to be. I've worked with lots of great clinicians who provide this to me as a matter of course, but I've met others who I've had to interrupt them or actually stop them before we're about to go into the interaction to ask them to provide me with some key information. Now, there's an actual script inside the guidelines, which is a guide for interpreters if they're unsure how to ask for a briefing. This is what you can do. If you don't mind, I'm the interpreter. I'll be working with you and the patient. Could you just provide me with some basic information? What things would you like to achieve in the interaction? Is this the first time you've worked with the patient? Is there anything about the patient that I should know in terms of their diagnosis or how they speak or sign, if they suffered a stroke? Are there physiological things? Are there any security aspects that I should be aware of? Are there going to be other family members, etc.? And if things happen in the interaction that are perhaps difficult, etc., do you want me to stop or intervene, or do you want me to wait until we can actually speak later and we'll have a debriefing? And look, that usually costs the clinician 2 or 3 minutes of time. But if you do make your request in this way, you style it in a way to say that you're not just helping me, but you'll also be helping yourself so that you can work optimally with the client, then almost all clinicians will be happy to provide you with that briefing. And that point before that you made about if a patient enters into what I call sometimes a stream of consciousness, where they just don't stop talking. They don't stop for you or pause for you to provide consecutive interpreting. When that has happened, I've actually switched to simultaneous. And it's been okay in the interactions when I've done this, but it might not be okay. So if that's another potential question to ask to your clinician beforehand. Do you know the difference between consecutive and simultaneous? Does this patient sort of stop to allow the interpreter to interpret? If not, can I switch to what's called simultaneous? What that means is I'll be speaking concurrently to the patient. Is that okay with you? Is that okay with the patient? If not, then you kind of then have to know that you're going to have to take notes while the patient is speaking at length, and then being able to give a rendition based on note taking and consecutive, if you like. So that's another logistic thing which can occur in mental health interactions, perhaps more so than in, let's say, general health interactions. In terms of ethics as well, I didn't know anything about patient rights, right to patient privacy, etc. You might have worked with a particular client and you might recall certain details about their medical history. Is it appropriate for you to share that information with a new clinician? Well, no, unless there's a very compelling reason, unless there's a reason for you to break that level of confidentiality, because what you know about another person's health belongs to that area of confidentiality that you don't share with other people. You don't. Only if there's a really emergency, life-threatening situation should you break, consider breaking confidentiality. And you should break it if there's a serious risk such as that.
Duty of care that comes in there.
Exactly, a duty of care. And also consider that the clinician probably has access to the patient's medical history anyway. So you're not the only one holding that information, even if you think you might be. Interacting ethically with clinicians means refers to the ethical principle of maintaining professional relations with others, etc. Being impartial as well and being competent. This means that if people say things which are nonsensical, etc., or perhaps incoherent, you don't make them sensical, you don't make them coherent, because the aspects of a person's speech or signing are critical for the clinician to know how they're expressing themselves, what they're saying, but also how they're saying. The characteristics of how a person speaks or signs can often be really, really important for diagnosis and for treatment.
Exactly right. And you mentioned earlier about asking the clinician, explaining the difference between simultaneous, or asking them if they know the difference between simultaneous and consecutive. But as you said, if somebody is speaking in a way that's completely incoherent, nonsensical, as they might be when they're having a psychotic episode, and they could have a psychotic episode because they've been taking methamphetamine, for instance, and haven't slept for 4 nights, consecutive nights. It's very difficult. I mean, you could actually take notes, but I find that if something doesn't make sense,
No.
I won't understand my own notes, because
Yes.
normally notes are based on things just hanging together logically in some way, shape, or form. But if people are being incoherent and jumping from one thought to the next, we're talking about cigarettes, riding motorbikes through the trees, then it's very difficult to interpret consecutively. But I guess we can't actually say to a clinician, I would suggest that if this happens, I move to simultaneous, or if the patient doesn't make sense, I may move to simultaneous, which means you'll hear my voice at the same time. Is that something we could do? What do you think?
Yes, we can. But to go back to that aspect about incoherent speech, it sounds really easy to say, oh, well, if they're speaking incoherently, you just produce a really incoherent interpretation, and it's much harder than it seems, because as interpreters, we're always looking for meaning, and we're always looking to make things sound coherent and concise and cohesive. So when we're confronted by a patient who's speaking incoherently, it's really challenging. Now, when I've taught this, the gold standard, if you like, if you can do this, you should try and replicate that level of incoherence and type of incoherence in your interpretation. And sometimes you can, if there's lots of hesitation markers and you switch from this topic to the other, etc. The clinician will typically recognize that the patient might be in a state of elation or agitation or whatever, and realize that what you're producing is the verbatim version of what they're saying. If you can do that, then good on you. And that's the gold standard, because you're providing the clinician with the translation of verbatim of the incoherent speech that you're hearing. But if you can't do that, and often you just can't do it because it's just hard or it's so quick or whatever, the strategy that I recommend is the following: that you keep the clinician informed of what the content is. Is it fish, smoking, going down the street, my neighbor's cat, etc. And then describing also what attributes of the form of their speech is really conspicuous. Is it slow? Are they repeating themselves? Are they using profane words? Are they talking about themselves in the third person? Are there really strange, let's say there's repetitions of particular words, etc. Where again, that's not actually, you're keeping the clinician informed of the content of what they're speaking, what they're saying, but then you give frequent accompanying descriptions of how they're speaking. And you might have said, I can't reproduce this myself, so I'm going to give you a description of what I hear for you to know how they're speaking, as this is helpful for your diagnosis. So that's the strategy that I recommend to students that they pursue if they're in that situation. You just can't replicate it if it's that challenging.
Speaking of profanities, because that just takes me back to the very first time I had to do mental health interpreting. I was in the hospital. I could speak Spanish, and so they'd identified me as someone that could act as an interpreter, not. And there was a sailor who'd just come off a ship that made a long journey to the Netherlands from South America. And he was using a lot of profanities, but they were a particular type of profanities. And I realized that I needed to, even though I wouldn't use those words myself, that's not me speaking, it's very important for the doctor to know what sort of profanities he's using, because to me it was almost like he may have been sexually abused on board of the ship. I don't know, but those were the types of profanities he was using. So I thought, okay, I need to just do my best to reproduce exactly what he's saying. Whereas I've had students, and I'm sure you have too, that say to you, look, I can't be heard to say that sort of word. I wouldn't use that sort of language. And you have to really say to these students, it's not you. It's so important, because the clinician can't take an X-ray of the person's brain to see what's going on. So as you said before, the speech is a very important diagnostic tool. And we as interpreters have to try and replicate that as faithfully as we can in order to help the clinician assess what's going on for that person at that point in time.
That's right. Look, I've trained students, and you need to be able to interpret profanities as they occur. Yes, they might be words that you might not use that much yourself, or you might not like using them, but that's not your call. Your call is to reproduce exactly what the words are, the F word, the C word in English, which I've done. It hasn't been pleasant, but I've had to do it because I need to show how disinhibited they're using disinhibited language. That's a key characteristic for, well, I presume it is for the clinician to know. And believe me, they're thick-skinned. In court interpreting, I've had to interpret this. The magistrates, people who work in this area are thick-skinned. They're used to people using quite vulgar or coarse language. This is part of our work. If people use it, we're obliged to interpret it.
Exactly right. And for instance, in the refugee setting, some clinicians working in the refugee setting with people who are severely traumatized through what's happened, they say that sometimes they felt that the interpreter was censoring that sort of language, and they said it doesn't actually help the applicant's cause, because this is a sign of how deeply traumatized they are. So there's on a whole lot of different levels. There's a problem with people taking it upon themselves to censor that sort of language. It's so very, very important.
You're actually distorting the source speech or signing if you take that away. That's a distortion. That's something we should not be engaging in.
That's exactly right. Now, if you were to say, step into an elevator, Jim, with somebody that's just said to you, Jim, I'm just about to go into my first mental health interpreting session. They haven't done a course with you, so they haven't had the privilege of learning from the best, and you were going up to level 20, say, in an elevator speech. How would you summarize the most important things for that person to know before going into that assignment?
I would say to them, do you know who you're working with, what role they are, kind of what they do? Maybe yes, maybe no. Okay. Secondly, ask for a briefing, and ask a few questions such as what I outlined before. Can I just ask you what this interaction is about? What do you hope to achieve? Are there any diagnostic tools? Are you meeting them for the first time, etc.? Keep yourself open to the fact that you might need to switch from concept to simul. Also foreground to the clinician during that briefing that you might need a debriefing as well. And don't try and make sense when there's no sense there. That can be a common mistake that newbies make, that we kind of teach students to make things sound good. And we do heaps and heaps of practice in the classroom, but if there's no sense in what the person is saying, don't invest sense in your interpretations. Replicate that lack of sense or lack of coherence. And if you can't do it, then describe it to the clinician. I guess those are the main points that I'd convey to a newbie who's going up that elevator to the 20th floor.
Their first mental health interpreting assignment. Jim, thank you so much for sharing your knowledge and wisdom with us. It's been an absolute pleasure to talk with you. Thank you.
Thank you again for the invitation, Ineke. It's been a pleasure for me to be here. And I wish all our colleagues well in the future, mental health assignments that they engage in. It's a growing area as well. I mentioned an aging population, and there's lots of more work in this area. So yeah, I'm open to questions, and I'm also pleased to report, and I think you're doing this yourself in Auckland, that mental health as a topic area is one which is receiving more attention in training courses, PD. So there's a bit more happening in this space, but we need to still work further. So this podcast is a good pretext for that to be on our minds as we move ahead.
Thank you so much, Jim. Thank you again.
Thank you. And thank you to all graduates as well for hosting this podcast.
Conversations Podcast.